wanted to thank the conference organizers for this chance to speak with you. My name is Michael, and I'm speaking to you from Seattle, Washington, the ancestral homelands of the Coast Salish peoples who have lived here from time immemorial. I wanted to express my deepest respect and gratitude for our indigenous neighbors, the Duwamish, Suquamish, Nisqually, Snoqualmie, and Muckleshoot tribes, for their enduring care and protection of our shared lands and waterways. I am also speaking to you approximately 3,000 feet from the Capitol Hill occupied protest, formerly known as the Chazz, or the Capitol Hill Autonomous Zone, birthed by police brutality against unarmed people protesting unchecked police brutality against Black people. I need to start this cure talk with politics because HIV is political. It is affected by politics in real ways. And if we do not insist that HIV is political, we will lull ourselves into believing that it is not political. HIV is political, so too will be an HIV cure. If recent events have taught us anything, it should be that we should not make any presumptions about our neighbors or know how they wish to solve the problems facing the world. If we think of HIV as not political, we will lull ourselves into believing that people are well served by being the object of charity, and they are not. That new therapies and discoveries towards an HIV cure will continue despite budget cuts. They will not. Or that people living with HIV are not affected by other institutional oppressions like racism, homophobia, discrimination, ableism, ageism, and great economic disparities. For they most certainly are. HIV is political. Therefore, HIV cure will be political. Think of this another way. Is this glass half empty or half full? We use this proverbial phrase to indicate a particular situation could be a cause for pessimism or optimism, or maybe as a litmus test to determine someone's worldview. But I want to use it to guide your thinking about the ways you can approach getting involved with HIV cure research. The more familiar deficit approach focuses on the problems, needs, and deficiencies in a community. It designs services to fill the gaps and fix the problems. As a result, a community can feel disempowered and dependent. People can become passive recipients of services rather than active agents in their own lives and the lives of their families. The shift from a deficit-based approach to an asset-based one requires a change in attitude and in values. Clinicians and researchers have to be willing to share power. Instead of doing things for people, they have to help community members do things for themselves. Working in this way is community-led. It is long-term and open-ended. An empowered community may not choose to act on the same concerns that clinicians or researchers see as the priorities for cure. Here's an example to ponder. In speaking with people living with HIV about the research related to an HIV cure, inevitably 3 burning questions tend to be asked. Who is going to get it? How much is it going to cost? And when are we going to see it? Often, these questions can frustrate researchers who maybe grow tired of the same questions arising again and again, but that's seeing it as deficits. Perhaps instead, we should see in these questions a burgeoning advocacy around Cure, one that focuses on promoting civil rights, ensuring equity, and optimizing the clinical trial pipeline. After all, that is the legacy left us by our ancestors who dared to act up. So, let me call out first to you who think of yourselves as community. It is time to talk with the people who have yet to be seated at the cure table. Most HIV cure trials are conducted in high-income countries and disproportionately enroll white men. That leaves us with a relatively small group of stakeholders knowledgeable about the basic science and the clinical progress of cure-related research. It is up to community to welcome to the cure table a broader scope of stakeholders from low-income and middle-income countries, but not only those countries, but also from places with high HIV prevalence, which sometimes are our cities, our neighborhoods, or our zip codes. Giving these new allies a prominent seat at the cure table will do more to clear up misconceptions and myths and dispel distrust and doubt than any program that tries to fix things. We cannot wait for someone else to do this. Community must help community. So, let us reach our arms out far and wide and welcome the people we know to be missing from Cure. Let us place them front and center, amplify their voices, and listen to what they have to say. Doing so will foster understanding of the facts. It will build trust, and perhaps it will instill some hope that one day a cure for HIV will come. And next, I'd like to address the clinicians in the room. Yo, clinicians, or healthcare providers, or primary care providers, whichever you prefer to be called. It's time for you to start talking to your patients or your clients about HIV cure-related research. As the Cole Porter song goes, if not you, who? In you lies an untapped well of potential advocacy for cure research among people living with HIV that you care for. You likely already have built partnerships with your patients living with HIV. It's probably the foundation of your care for them, so you are already halfway there. This relationship between provider and patient really became evident to us when we published qualitative data from a focus group discussion study with people living with HIV in the Seattle, Washington area on the acceptability of cell and gene therapy approaches to curing HIV. Participants expressed fear about cell and gene therapy research, concerns about the risk, and they voiced significant mistrust of research in general, believing there was already a cure for HIV that was being withheld from the poor. The trust conferred to primary HIV care doctors sharply contrasted with this distrust in medical research. We concluded that the support and the approval of participants' primary HIV care doctors will be critical in making decisions about clinical research participation, especially when there is no direct benefit to the participant. If you need further evidence, take a look at these percentages. 83% of people who were surveyed said that a doctor's recommendation would likely influence their participation decision. 58% rarely, if ever, considered discussing clinical research options with their doctor. 85% of them individuals are generally comfortable presenting any clinical research information that they find to their doctor. However, only 17% have actually presented clinical research data to their doctor. But when I use the word clinician, I mean more than physicians. Now, you may not think of yourself as a clinician, but if you work as a caregiver to people with HIV in any capacity, I'm talking to you. You owe it to yourself, you owe it to your HIV positive clients to keep up to speed with accurate cure-related research developments. There is still so much for us to figure out around cure, and we need all clinicians to help us. We must place cure in context with HIV prevention and treatment. Scientists that I'm lucky enough to work with at Fred Hutch have created a mathematical model of heterosexual HIV transmission to evaluate the impact of ART, HIV prevention interventions, and cure on HIV prevalence and incidence. They found that a cure would have limited impact on HIV incidence if only patients on ART were eligible for cure. But they found a significant impact on the incidence of HIV if untreated patients were enrolled directly into cure programs. Concurrent HIV prevention programs would moderately decrease the percent of ART-treated or cured patients needed to achieve elimination. And when it comes to ending the HIV epidemic in America, it may be true that we do not need a vaccine or a cure in order to achieve our goals. But we ought to reconsider this in the way we approach this important work. People living with HIV can feel left out of the ending the HIV epidemic plan. Many do not understand how lowering transmissions will end the epidemic, and why ART and PrEP are enough to do it. In their lived experience, the epidemic will not end until they are totally free of the virus. Talking of cure in the context of ending the HIV epidemic would be aspirational for people living with HIV and for the general public. So, to conclude, yo community, you don't have to wear a lab coat to help us find a cure for HIV. And yo clinicians, you don't have to work in a lab to help us find a cure for HIV. There are many ways for community and clinicians to get involved with and get informed about HIV cure-related research. If you pay attention, this meeting will offer you a few. Your unique talents are very much needed in ways left for you to figure out. But trust me, there are pathways no one has dared yet to map. So remember, that proverbial glass is half full, always. And remember that there will be no cure for HIV without you. Thank you, and may you enjoy your conference.
That's right.